fortunately been several positive positive developments. One is we're able to make a better awareness of the patient, especially since it is a preventable disease in some cases due to exposure to nicotine or working related toxins. Then because of that awareness and because of having campaigns which is now supported by the European Union against smoking, then this can be maybe prevented in some cases. Then on the other hand, when you want to diagnose bladder cancer, or if you suspect it, let's put it like that, then biomarkers can help you to see which patients might need for example, cystoscopy or even biopsy. Then if a cystoscopy or biopsy has to be done due to the clinical situation or because of biomarkers showing an indication of a suspicion, then a better detection of these tumors or the areas where you should take the biopsy is then something that really helps finding the real disease and then see the extent of the disease, and then according to that make a strategy that could lead to either cure or cure with even prevention of doing a major surgery. On the other hand, and we have seen this at the most recent meeting of the European Association of Urology and in some just most recent literature, that even non-muscle invasive bladder cancer can be stratified according to their molecular substaging, and even more so in finding signs of tumor DNA floating in the blood. This has most recently been shown for muscle invasive or advanced disease of high risk, of poor prognosis, then to follow these patients and see whether they should or will have immunotherapy. And on the other hand, it has been shown now also that in non-muscle invasive disease, which sometimes can be really aggressive and which may lead to progression unless not treated with all what we have in our armamentarium, that these can be also maybe stratified according to their molecular substaging as well as a circulating tumor DNA in the blood. I think these are enormous prospects. And what we have also seen that if we take immunotherapy, checkpoint inhibitors, for example, and if we use these checkpoint inhibitors after a normal chemotherapy, or in those cases where there is a high risk of a recurrence after cystectomy or radiotherapy, that an immunotherapy in an adjuvant setting, that means without seeing any tumor, may really give these patients maybe even cure if we have the immunotherapy or checkpoint inhibitor therapy long enough. The dream would be, the vision would be to not even have patients become an invasive or metastatic disease, so that the earliest detection. Prevention is, of course, a big wish, of course, but even early detection and detection at a time when we could do it with acceptable means, cure or remove the disease, that is a challenge and an unmet need. But also, to be a little bit more modest, the possibility of having a non-chemotherapeutic possibility in the very advanced diseases to prolong systemic therapy, but with an acceptable morbidity, and with that prevent progression and even death, that is something that seems to be possible within the next few years. What is even better is, not everyone will need it, and that we better classify the patient, the individual patient, whether he would need systemic therapy, or would not only need it maybe for a certain time, or not even need it because we don't see any disease and it's not going to come. We don't have enough data in some cases. And registries for bladder cancer would be is an unmet need. It's a desire, and I think that is something which we should really make every effort to get data and see how some of the patients with non-muscle invasive as well as advanced disease fare, and how they respond to different forms of treatment which are already available. Registries is necessary.